On behalf of the American Heart Association, I would like to welcome you to Advancing HFpEF, HFmrEF Identification, Hospital Insights, and Real-World Solutions. This event is made possible through the American Heart Association's Implement-EF initiative, which is a 3-year initiative supported by Bayer that is designed to improve HFpEF, HFmrEF, inpatient care by gaining insights on current unmet clinical needs and practice pathways, with a focus on evidence and science-based therapies. We will have a number of educational events throughout the duration of this initiative and encourage you to visit the website at the link on the screen to learn more. We have convened a 40-site cohort of multidisciplinary hospital teams seen here. Before we begin, I'd like to quickly review how to use this platform for today's event. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please review the system requirements or contact the Zoom webinar helpline. To access live closed captions, please click on the closed caption button found on your screen. All participants have been muted and cameras are disabled. Throughout today's presentations, you will have the opportunity to submit text questions for our presenters using the Q&A feature on your control panel. You may send in your questions at any time, and we will review the questions during our Q&A at the end as time allows. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the American Heart Association, American Stroke Association. The American Heart Association does not endorse any product or service. Finally, this webinar will be recorded and available on the Implement-EF website next month. Today's presenters are Jessica Nensel and Geri Montelongo. Jessica serves as a program coordinator for the cardiovascular service line at the University of Colorado Hospital. Her role focuses on program development for both the heart failure and acute MI programs, which includes quality initiative implementation and evaluation of program services and practice standards to achieve the highest outcomes. Geri serves as a heart failure clinical coordinator and certified heart failure nurse, with over 25 years of nursing leadership in cardiovascular care, quality improvement, and community engagement. Geri is recognized for nurse-led system redesign, registry excellence, and sustained improvement in national quality metrics. She is Lean Six Sigma Green Belt trained and working on her MSN. With that, I will turn it over to you, Jessica.
All right, thank you. As Nancy mentioned, I am Jessica Nensel. So I am the program coordinator for the cardiovascular service line at University of Colorado Hospital. I just want to first start off by saying thank you to the American Heart Association for this opportunity to speak today. We're excited to share some of the tools that we have at our hospital to help our teams better identify heart failure patients with preserved or mildly reduced ejection fraction. I have no disclosures. So a little bit about University of Colorado Hospital. We are located in Aurora, so that is a suburb of Denver. And we are part of the UC Health System, which is one of 14 hospitals in our region. So for University of Colorado Hospital, we have 844 beds. Listed there some of our volumes, so we are a pretty busy center. Also listed there are some of our center designations as well as our certifications through the Joint Commission. Like I mentioned, we are part of a larger system. So University of Colorado Hospital has been ranked #1 in the state of Colorado for, actually I think it's the 14th year in a row by US News and World Report. Also followed closely behind 2 of our hospitals within our system, ranking in the top 5. University of Colorado Hospital also has recently been designated their 6th magnet designation through the American Nurses Credentialing Center. So very proud of the focus of quality, both locally and nationally, that our hospital has. So a little bit about our heart failure population at University of Colorado Hospital. So this is just a breakdown of our data from calendar year 2025, just to kind of give you a picture of who our patients are and where they're being managed during their hospitalization. So last year, we had 815 patients discharged with a primary diagnosis of heart failure. So breakdown classification of that, so about half of those patients were heart failure with reduced ejection fraction. About close to 40% behind that is our preserved ejection fraction, and then the remaining 10% were the mildly reduced. Also looking at who's caring for these patients and where. So our discharging service. So the bulk of our patients are managed on our cardiology service. They're in the yellow, but 40%. After that, it's kind of split down the middle, with a third of them being managed on our advanced heart failure service, and then the remaining on our non-cardiology services at 30%, which usually is like our hospital medicine that's managing those patients. And then where are these patients located throughout the hospital? We actually do a pretty good job of cohorting our patients on cardiology-based units. So again, a third of our patients are on our cardiology medicine floor. A third of our patients are on our cardiac ICU. About 10% are on a cardiac short stay post-procedure unit. And then again, the remaining 30% are on our non-cardiology unit. So those are primarily the patients that are on our hospital medicine services. So what are some of the challenges that we do have with identifying heart failure earlier on during their hospitalization? So like I mentioned, a third of our patients are on non-cardiology services. So we know that our hospital medicine colleagues like to use their own order sets. So therefore, they're not using our guideline-based cardiology order sets, as well as during their multidisciplinary rounds. Maybe some of our key heart failure interventions aren't necessarily being addressed during those discussions on rounds like they would be during our cardiology rounds. And so therefore, some of our key metrics and physicians of care elements may be missed, such as follow-up visits, GDMT medications on discharge, our OPA alert. So we'll get into a little bit more of this in a little bit, but we know that our OPA are alerts that fire for providers. We know they're not perfect. We know we're still not capturing all patients on admission, as well as providers can defer these alerts, so they can kind of ignore them and kind of go about their day. The alerts also still do have an aspect of manual chart review. And then we do appreciate the fact that the sensitivity and specificity of the criteria that's actually firing for these alerts, that's making them trigger, is challenging. So making sure that they're not over or under firing. I think we can all kind of appreciate the challenge of these patients who are presenting with hypertensive heart and chronic kidney disease, the trifecta of heart failure. And so those patients can be challenging on admission to know really what is the driver of their admission. And so I feel like, was it a missed dialysis session, or what the cause might be? So those can be challenging. So we are working with our coding and our clinical documentation integrity teams around concurrent coding. We do have that live at our hospital. There are still some limitations with that, so ongoing efforts to be done with that. We are an academic facility, so we do have house staff and residents, so they rotate on a monthly basis. So there's ongoing education when they come on for their cardiology rotation around our evidence-based guidelines, use of our order sets, and some of our key quality metrics. And then we've really been able to identify that some of our missed get with the guidelines metrics around physicians of care really are our preserved ejection fraction patients and mildly reduced. And I think a lot of that just goes to the fact that sometimes those patients aren't necessarily on our cardiology services. So therefore, heart failure education may not be ordered and therefore may not be done prior to discharge, and as well as reinforcing that 7-day follow-up. We do have some EPIC tools, which we'll kind of get into the meat of the presentation here, that we have to help assist us with identifying these patients. So we have EPIC tools on admission and discharge. So those include our OPAs, or our practice advisory alerts, or also previously called through EPIC best practice alerts. We have our order sets, so admission and discharge order sets. We as well have patient lists. So we have one based off of EF, one based on HFpEF being listed on the problem list. So we have a variety of EPIC tools, as well as we do have a heart failure banner on our care progression report in EPIC, as well as an OPA around ARNIs. So this is one to encourage providers, if clinically appropriate, to order ARNI on admission or discharge. These are all tools that we have within EPIC to help us identify these patients a little bit earlier. So getting into our practice advisory OPA on admission. So this is a screenshot of what this looks like. So really, the purpose of this OPA is kind of twofold. One, there's criteria running in the background in EPIC, and if those are met, this will fire for the provider during their admission process. So one goal is to get the provider to think, yeah, this patient may be here for heart failure. Please consider using our cardiology and heart failure-based order sets. The other aspect of it is one, when this alert notifies, we get an in-basket notification as the quality team that this fired. So even if the provider did or did not use the order set, we'll be notified. So then we can go back later and kind of see what's going on with the patient. And in regards to the order sets, we do have links here that the provider can choose to open up the cardiology admission order set and or the heart failure focused order set. As well as within this OPA, it's kind of nice that if the provider's like, why is this firing for me? What is this? They can click on the hyperlink of why am I seeing this, and all of the criteria of what's making that OPA alert for them is listed there. So when that OPA fires on admission, we then get a silent EPIC in-basket notification for the quality team. Like I said, whether or not the admission order set was used, we get notified that this fired. There, circled there are all the triggers that made that OPA fire. As I mentioned, there still is the manual chart review process for this, for us to go back in and see like, what's going on with this patient? Why are they coming in? If they're primarily here for heart failure, then we'll add them to the appropriate heart failure inpatient list. And this list is then shared with multidisciplinary teams. So pharmacy, nursing, care management, PT, OT. And so this list is manually updated. You can choose whatever columns you would like to include in there. So we've included like length of stay, estimated discharge date, a queue for if they've been readmitted in the past 30 days. We also like to include a payer source. And then we also have tools running in the background for heart failure education, which are those green, yellow, red dots. So green, and as well for heart failure education, as well as heart failure medication education. So green being if heart failure education's been added and documented during this admission. Yellow being heart failure education's been added but has not been documented on. And red is that there's been no heart failure education for this admission so far. As well as an in-basket notification, we also get notified. So one of the OPA, as well as if the cardiology admission order set is used. So this, again, this is a notification in our in-basket. This is not a push to the providers. They don't see this. This is just another way that, let's just say they decided to use the CARDS admission order set, but they're not quite sure if it's heart failure. So they didn't want to add the heart failure focused order set yet. This is just another way of us being alert that, hey, a cardiac patient's coming in. What's going on with them? Again, this does require a manual chart review process, but we go in, review, and then depending on what's going on with the patient, we'd add them to the appropriate patient list. So whether that's heart failure inpatient list or an acute MI patient list. Our cardiology admission order sets are also another great tool that we have. We're kind of proud of our order sets, and that I'll mention that we are an academic facility. So there's a lot of education to house staff. So we really encourage them, if you have any cardiac admission need for orders, please use the cardiology admission order set. It's kind of like a one-stop shop for all cardiology orders. It has all of our evidence-based guidelines in them, automated consult orders, as well as we kind of look at the cardiology admission order set as like a big umbrella. And within that umbrella are all the different diagnosis-specific focus order sets available to providers to use. So we've got heart failure built in there, acute coronary syndrome, mechanical circulatory support, AFib, and then we know that the majority of our cardiac patients use our ACS-AFib heparin protocol, so we also have that built in just kind of like as a convenience for providers, once again, a one-stop shop. And so within this order set, we've got automated orders for GDMT has to be addressed, why or why not they're ordering it, multidisciplinary team consults if appropriate, and then ensuring that the appropriate diagnosis-specific education is ordered for the patient. So this is a screenshot, and it's kind of busy, but this is a screenshot of our cardiology admission order set. So that first big box is that big umbrella that I mentioned of a cardiology admission order set. And then within there is the circled, it asks the provider, hey, do you want to open up any of its applicable orders for the patient, whether that's ACS, AFib, heart failure, what it may be. And that's when this smaller box opens up for them to select. They can select any or all of them, whatever may be clinically appropriate for the patient. So that's some of our tools on admission. So now looking at discharge, again, we have the OPA that fires on discharge, similar to the admission OPA of, hey, this may be a heart failure patient, consider using this order set. And this one has the link to the cardiology discharge order set. Again, we get a notification in our in-basket that this OPA fired. It includes all of the triggers for what that made that OPA trigger fire for the provider. Again, this is not to the provider. This is more just behind the scenes in-basket notification. It does require a chart review to kind of see like what's going on with this patient. Were they here for heart failure? And if so, we would then ensure that all of the key heart failure interventions were in place prior to discharge. We have the cardiology discharge order set. So similar to the admission build, kind of a one-stop shop for all cardiology discharge order needs. It addresses all the guideline-directed medication therapy, addressing why or why not they're going home on something, addresses all transitions of care. We have some kind of unique, we've got these wizard tools built in to our cardiology discharge order set for follow-up appointments. So it helps providers determine what is the appropriate follow-up based on the patient and who saw the patient in-house. Also, it incorporates their payer source. So knowing where they can go and where they may not be covered to go. We also include outpatient consults, and then for heart failure order set, the heart failure education. So again, for this, our discharge order set, the diagnosis-specific focus order sets included our heart failure, acute coronary syndrome, mechanical circulatory support, and then heart transplant. So this is a screenshot from our cardiology discharge order set. So that left box is just kind of, again, that big overarching umbrella of the cardiology discharge orders. It's all the generic orders that would apply to almost all patients. And then within there, they can choose to open up any of these focused order sets linked below. We do have rules in the background that if certain criteria are met throughout the hospitalization, discrete data points, these specific focus order sets will automatically populate for the provider. They can always choose to open or remove any of these order sets though if they feel like it's not clinically indicated. And then this is just a screenshot from our heart failure specific discharge order set. Really, it's just kind of encompassing, I think we all include in our discharge education, but reinforcing their follow-up. We pull in the date and time of their follow-up appointment. We pull in, information, education on home management, when to call, worsening symptoms, ensuring that they receive their heart failure patient education book. We pull in their most recent weight and their most recent EF, as well as we provide links to heart failure education classes that we offer and heart failure videos that we provide to patients. All of this is included in our discharge order set, which then populates to the patient's discharge ABS. So we do have some additional tools that may or may not be EPIC focused. So to help us identify patients, we have cardiology multidisciplinary rounds. So these happen Monday through Friday in the afternoon. It's really kind of all encompassing of the entire team that cares for these patients. So we have our provider, usually our resident or house staff, nursing, care management, pharmacy, all at the table. Really kind of the goal of this is just kind of like a rapid fire, go through all the cardiology services, a brief, run through the hospital's patient's hospital course and what are predicted needs for discharge? What do they need, in order to go home? And so kind of, through these rounds verbally, if any of the previous tools that we talked about didn't, fire or alert our team of these patients, rounds would maybe be a good way to hear if verbally it's mentioned that the patient is here for heart failure or if their heart failure is being managed. Our inpatient heart failure nurse navigator attends these rounds, so it's a great way for her to collaborate with all the team members. We do have a heart failure banner. So our care progression report in EPIC is kind of like all the things going on with the patient for their admissions. Talks about their length of stay, predicted discharge. All the multidisciplinary teams have their place to document any notes or FYIs to all the different other team members. So we do have under the notifications, if the patient's here for a heart failure exacerbation, We do have this available on the care progression report. Really, it's just a visualization to the multidisciplinary teams, because this is what's used during MDRs, is they run through the care progression report. So it's kind of a visual cue that this patient's here for heart failure, and we want to ensure all the key heart failure interventions are in place prior to discharge. It's also a cue for our case managers. If the patient's going home with home health care and they're here for heart failure, they should be going home with an RN order for that medication management. We also have a heart failure volume overload pathway. So really the goal of this is to help our patients who are on non-cardiology services, so primarily our hospital medicine services, and they're here for heart failure, to help guide them with diuretic management. So we looked at this. This is available under our pathways and EPIC. It's really kind of neat. We're very pathway driven here at University of Colorado Hospital. All these orders, all these purples are all hyperlinks to orders. So they can go through kind of put in what their home diuretics are, or if they are, diuretic naive, adding where to start. And so all of these are orders that can be placed through this pathway. And it also kind of walks them through, like when to consult cardiology and or renal, if clinically appropriate. And so we do also have a link to this pathway within our, trying to get this to advance. I think I'm frozen. Okay, thanks. So we do have a link to this heart failure volume overload pathway in that admission OPA, like I mentioned. So those blue boxes are links to the cardiology and heart failure focused order sets that the providers can choose to open from this OPA. Or if they're like, I don't want to use the order sets, but maybe consider using this volume overload pathway. So that's available as well. We have an inpatient heart failure nurse navigator. So she is amazing and instrumental in the daily coordination of our heart failure patients. She really helps with ensuring timely and appropriate follow-up, improving use of guideline-directed medical therapy, and of course, the essential heart failure patient education. We do have a consult order automated for her to be placed if the heart failure focus order set is used. The consult for her can also be placed as a standalone order, but if the heart failure focus order set is used, it's automatically placed for her. So I guess looking at next steps and future goals, and that's kind of the exciting part of us participating in Implement EF, is I think it's really opening up, like, where can we really start implementing and inserting some of the HFpEF and mildly reduced clinical guidelines. I feel like we could look at incorporating them into our cardiology order sets. We really, like I said, we use our cardiology order sets as kind of like an educational tool as well for our providers. And I think through our process mapping with the Implement EF team, we found that we do have opportunity here for education to not only staff, but as well as our providers around the HFpEF clinical guidelines and management. So incorporating that into our monthly resident education when they come on cardiology rotation. We do send out weekly quality metric emails to our attendees and our house staff. So incorporating it there, as well as nursing staff lunch and learns. I mentioned our concurrent coding efforts in collaboration with coding and CDI and ongoing efforts there. And then we know our OPAs are a great tool. They're not perfect. And so we know that there's always that challenge of, that criteria being just right and making sure we're not doing too much in the provider space, but also capturing the right patient. So we are ongoing efforts and actively looking at updating our grouper list for our OPA to see if that will maybe capture more of the appropriate patients using ICD-10 grouper list. So I just want to say thank you for your time today, and thanks again to AHA for the opportunity.
Thank you, Jessica, for that excellent presentation. Just a reminder to our audience, please don't forget to submit your questions using the Q&A feature on your control panel. Next up, we have Geri Montelongo from UC Health Memorial Hospital in Colorado Springs, Colorado. Geri, the floor is yours.
Thank you. Good afternoon, everyone, and thank you for joining today's session. My name is Geri Montelongo, and I serve as the Heart Failure Coordinator at UC Health Memorial Hospital in Colorado Springs, Colorado. I have no disclosures to report. Today, I'll walk you through how we use Epic tools, specifically our practice advisories, which will be labeled OPA on your screen, and Nurse Navigator patient lists to improve real-time identification of our HFpEF and our HFmrEF patients. In UC Health South Region, we serve Colorado Springs and surrounding communities across multiple acute care hospitals, representing a combined capacity of about 680 inpatient beds. From a heart failure perspective, this creates both scale and complexity. Heart failure patients are admitted across all units, especially under hospitalist care, not cardiology, as in the UC Health, in Jessica's model. At Memorial Hospital and across the South region, cardiologists do not admit heart failure patients. They are merely consulted on the hospitalist patients. Hospitalists are the primary admitting and managing providers, and cardiology is consulted selectively, most often for patients on inotropic drips in the ICU, new heart failure patients, or advanced or end-stage heart failure patients. I think I was one behind there. Let me look here. Just a sec. This model means that heart failure care depends heavily on hospitalist familiarity with heart failure guidelines, which varies widely across a large provider group. We are fortunate to have a hospitalist heart failure champion provider who helps reinforce guideline-directed medical care, but system-level support is still critical. To address these challenges, UC Health adopted a systemized, data-driven approach aligned with implement heart failure goals, early identification of HFpEF and HFmrEF, accurate classification, and timely initiation of evidence-based care. Nurse navigators and registry coordinators are central to this work. They translate data into action by partnering with providers, quality teams, and IT to ensure the right patients are identified early, regardless of admitting services or unit location. Another major challenge is we do not have a dedicated heart failure unit. Heart failure patients can land on any unit across more than 680 rooms in our 4 hospitals. So why Epic tools, IT tools are essential? Without automation, identifying heart failure patients manually for us would consume most of our day. This is why Epic tools are not a convenience for us. They are essential. Despite not having cardiologists admit heart failure patients or a dedicated heart failure unit, these workflows allow us to meet American Heart Association guidelines. Early identification and navigator oversight help normalize heart failure care, regardless of the admitting provider or the unit location. This slide shows how heart failure identification and care coordination occur across roles rather than in silos. In the provider lane, you will notice that the process begins with the provider. Heart failure is captured as acute or acute on chronic through OPA firing. Providers use smart links for structured heart failure documentation, and Epic Chat allows direct communication with the heart failure nurse navigator. This documentation and communication are the trigger points for early heart failure identification. Heart failure nurse navigator lane, once flagged, The navigator reviews the OPA list, performs snapshot review and clinical validation, and confirms heart failure relevance and phenotype. Validated patients are tracked on the heart failure patient list with sticky note documentation. This is where clinical judgment and operational oversight intersect. The next one is the registry Get with the Guideline heart failure lane. Early identification improves phenotype clarity, especially for HFpEF and HFmrEF, and supports accurate, timely abstraction with fewer missed cases. The last lane is the multidisciplinary care team lane. Once validated, pharmacy, cardiac rehab, and outpatient navigation engage early, supporting medication access, education, and follow-up. And together, this swim lane shows you systemization, how that amplifies clinical judgment rather than replacing it. Okay. Now I want to bring this down to bedside level and walk you through my own personal workflow. I start on the OPA list, which is, let's see, yes, that's the one. I start on the OPA list, which is automatically populated in Epic. This replaces the traditional OPA terminology for us and reflects how we operationalize heart failure identification locally. This list gives me early visibility into potential acute or acute on chronic heart failure admissions. From the OPA list, I move to the Snapshot tab. This gives me a concise overview without opening the entire chart. I pay close attention to the problem list and the dates tied to each diagnosis, so I can determine whether heart failure is relevant to the current hospitalization. This is where clinical judgment is critical. If acute or acute on chronic heart failure is listed in the current visit, I do a manual chart review to confirm whether the patient is truly admitted for decompensated heart failure. This step prevents over-inclusion while ensuring that we don't miss true heart failure patient admissions. Snapshot also shows recent ED visits and hospitalizations, which helps identify utilization patterns and readmission risk. Future appointments help me coordinate follow-up care early and avoid duplication. Once validated, I move the patient onto my heart failure admission patient list, which becomes my primary workspace. This list displays customizable columns. I've chosen unit, admission date, expected discharge date, length of stay, sticky note, diagnosis, registration coded, registration coded as a diagnosis, which may or may not be correct, discharge disposition, and the most recent documented ejection fraction. This allows rapid prioritization without opening multiple charts. This is a shared list, so other members of my team can also see this very quickly. My sticky note is my navigation memory tool. I document guideline-directed medical therapy follow-up needs, comorbidities, labs, consulting cardiologists, insurance considerations, readmissions, and referrals that I've sent. This information persists across encounters for me, allowing longitudinal tracking when patients return. I share heart failure patient lists with outpatient pharmacy, phase 1 cardiac rehab for education, and the outpatient nurse navigator. Epic Chat provides closed loop communication with case managers, providers, or my outpatient nurse navigator. This ensures heart failure patients are identified, followed, and supported in real time. This process works because it blends automation with clinical judgment. OPA gets patients on my radar early, but validation, tracking, and coordination are navigator-driven. The result is better continuity, stronger collaboration, and fewer missed opportunities. To further support heart failure identification, we partnered with our IT analyst to develop a specialized heart failure patient list aligned with American Heart Association, yet with the guideline heart failure definitions. Patients are categorized into HFrEF with an ejection fraction of 40% or less. And I know on my slide it says something a little different, but we have changed it. HFmrEF with patients between 41 and 70%, and inpatient HFpEF. This categorization helps ensure we're accurately identifying heart failure phenotypes and not overlooking HFpEF or HFmrEF patients who may not trigger our previous traditional workflows. From a clinical standpoint, this structure promotes consistent phenotyping and supports guideline-directed evaluation. From a registry and quality perspective, improves data integrity by flagging patients who may need further EF documentation or clarification. Operationally, it allows nurse navigators to focus their time where it has the most impact: patients nearing discharge, those with high readmission risk, and those who may benefit from early education and follow-up planning. The Smart Link is another layer of reliability in our identification process. By standardizing provider documentation using discrete drop-down fields aligned with AHA definitions, we reduce ambiguity for nurse navigators and registry coordinators. This allows earlier, more confident identification of HFpEF and HFmrEF patients and improves both care coordination and data quality. The Smart Link strengthens heart failure identification by standardizing provider documentation in a way that directly supports nurse navigator visibility and downstream registry accuracy. Required or encouraged fields include heart failure diagnosis confirmation, heart failure phenotype, the HFrEF, HFmrEF, and HFpEF, NYHA classification, guideline-directed medical therapy, and free text for exclusions and ICD placement. The biggest impact of this workflow is early nurse navigation review. By identifying HFpEF and HFmrEF patients early in the hospitalization, we can intervene sooner, providing education, reinforcing follow-up, and coordinating care before discharge decisions are finalized. This approach reduces missed opportunities, supports smoother transitions of care, and strengthens alignment with AHA. In closing, HFpEF and HFmrEF identification requires intentional design. OPA tools are most effective when paired with navigator lists and clinical validation. Aligning tools and definitions with American Heart Association, yet with the guidelines heart failure, strengthens both patient care and registry reporting. This work truly takes a team from IT to clinical leadership to national partners. This is a shared effort to improve heart failure care for our patients. We're grateful to be part of that larger community. If you're thinking about how to replicate this all at your facility, the core steps are very simple. Identify patients early with a system trigger. Validate clinically with navigator review and track them on a single share list through discharge with a multidisciplinary team. If you're saying to yourself, we don't have all these tools, even without all of these tools, the minimal requirement is a reliable way to flag potential heart failure admissions and a navigator empowered to validate and track them. Thank you for your time and for your work and for all the work you do supporting our heart failure patients, quality improvement, and American Heart Association, Get with the Guidelines Heart Failure. I'd love to open this up with discussion. Many of us face similar challenges around this identification, EF documentation, and registration accuracy. There is no single right answer, but sharing what works and what doesn't help us all refine our process.
Thank you, Geri and Jessica, for those fantastic presentations and for sharing such valuable insights with us today. Your expertise adds tremendous depth to this discussion, and we truly appreciate the clarity and the thoughtfulness you both brought to this topic. Just a reminder to our audience, please submit your questions using the Q&A feature on your control panel. We will spend the rest of the time addressing some of the questions we've received. If we don't have time to address your specific question, please don't hesitate to email us at the initiative implement.ef@heart.org, and we added that to the chat. So I've been looking at the questions, and we have some really, really great questions and comments. Let's start with one for you, Jessica. In regards to the Epic tools you discussed, are they already available or did you have to have these built?
We had them built. And I will say, I mean, some of these tools like the OPAs have been in place for years, for at least 10 plus years. We've obviously refined them over the years. And I think I know a couple of different things that we've heard about from other sites that we went to our Epic people and we were like, hey, is this available? So I think hearing about other sites and what they're doing, obviously it all kind of depends on what version of Epic is available and what you have. But yeah, but the majority of these, we had these created.
Yeah. I'm going to tag this next question on for you, Jessica, and the comment was that was an excellent presentation. And then has your center seen increased prescribing of ARNI after the OPA implementation?
Yes, we did actually. I would say we had that implemented probably 2.5 years ago. It was right when ARNI was kind of coming out and we were just really struggling with pushing that education out to our house staff. So it took a while to get that approval and to push that ARNI OPA through, but we were probably about 50% prescribing. And 6 months after implementation of that OPA, we jumped up to like 72%.
Wow,
so we have
amazing.
definitely waxed and waned since then, and we still are identifying opportunities in our ARNI, and a lot of that we're seeing mainly around documentation. But I will say we've heard from our clinical decision support team from Epic that that's a very well high functioning OPA for them to have that level of response and interaction from providers.
Excellent. Kind of keeping with the OPA alerts. Another question is, through SGLT2 inhibitors is not a 1A. Has your facilities made it part of your OPA systems?
We haven't yet. And overall, we actually do pretty well at University of Colorado Hospital with our SGLT2. So we haven't explored that for the need of an OPA. We just haven't had that need, not to say we won't. But obviously our CDS team, the team that really kind of pushes out OPAs, they're all obviously very cognizant that we're not just putting alerts in providers' faces. I don't know if that one would be as successful to get approved just because we do tend to do pretty well with SGLT2 here.
Wonderful. And Geri, I'll ask you this one. How long do patients stay on the list? Only as long as they are inpatients, or do you have to manually remove them?
I do manually remove the patients. I actually keep them on my list for about a month so that I can tell if they've readmitted. And so that way, when they show back up on my list, I will know that they're back in the hospital early on.
Wonderful. A lot of great feedback from the audience on both of your presentations. Let me find another one. Question to Jessica, what triggers the heart failure banner?
That is one of our newer builds. So what triggers that is that there is a heart failure inpatient consult order placed for our nurse navigator. So in order to get things onto under the notification section of the care progression report, there's limitations of what that is, and one of those are specific consult orders. So that was kind of our best route to get that populated. So it's not perfect, because we know that not everyone is placing a consult order for our inpatient nurse navigator, but at this time, that's what we have triggering that. And that's probably been in place for about 4 months, so not too long.
And Geri, I'll kind of take this on to the last question. What is your process when a patient that you know is heart failure, but the diagnosis, the principal diagnosis, is incorrect at discharge?
I guess that's a little confusing. When I think that when it looks like acute on chronic heart failure or acute heart failure to me, but the provider says that it's pneumonia or something like that. Is that kind of what?
Yeah, I think so. Yep.
Yeah, I mean, when patients come in, their diagnosis could be pneumonia, and then at the very last minute of the discharge, the discharge provider documents acute on chronic heart failure. I mean, I watch all these, and those are some of them that we can definitely miss. But I think the opposite isn't as true as when patients admit with a respiratory diagnosis for us, and then they end up coding out acute or acute on chronic heart failure. And again, that's this kind of clinical expertise. On my end, I've gotten a feel over the years for patients who are admitting with pneumonia, but they're talking a lot about Lasix and volume overload. And so, I just work them up as if they're acute or acute on chronic heart failure patient. I add all the education on for the patient. I'm still getting them a transition of care appointment. So I am, I guess, overcompensating and assuming that they could code out heart failure, but it's always hard to know. We will be coming into a future where we will have documentation that is real time. We're not there yet, but I think that will help us tremendously.
I've heard this question quite a bit, and either one of you could take this one. For a patient admitted over the weekend and discharged right away, how do you avoid missing those patients? And what does follow-up look like from the heart failure navigator perspective?
I can take this one. If patients are admitted on a Saturday and discharged on a Sunday, they are still going to hit my BPA list. They're still going to be transferred over to my patient list. I'm still going to look at them the same exact way that I look at every other patient. So that BPA list is firing 24/7. So I typically don't miss very many patients because of the weekends. And the second part of it was, what was the question in the second part, Jennifer?
It was, what does follow-up look like from the heart failure navigator perspective?
Yeah, so I do transition of care with our follow-up. So I'm still going to send a referral to our transition of care company or our transition of care clinic so that they can follow up with that patient on Monday morning. Monday mornings are super, super busy for me because I'm getting caught up on everybody that was discharged after hours on Friday, all day Saturday, all day Sunday, and then Monday morning. So, and then Fridays tend to be our big discharge days. So that's also a very busy time for me.
I think this one would have been for you, Jessica. The question is, would be interested in hearing more about the post-discharge virtual medication education classes that you listed on one of the slides for the discharge order.
I think Geri can actually speak to that one.
Okay.
That is our Healing Hearts Academy that she kind of steers
Wonderful.
up.
So we have a Healing Hearts Academy. We had been meeting monthly for classes for patients. Patients are able to sign up online on our uchealth.org site, although we're a little bit of transition with platforms right now. But we have different topics. So we have 6 different topics through the year, and then it repeats. So every month we have a different topic. We do have pharmacists that present our medication class. So it's about a 45-minute class. It's virtual, or patients can do in person. In Colorado Springs, we don't have an in-person option for every city, but patients just join virtually. The pharmacist goes over everything that is heart failure, sometimes extra cardiac information, medications, and then they can ask questions virtually also.
Then just notification for the audience, if you were looking for today's presentation slides, they are posted in the chat, or you can find them on the resources tab on your control panel. And then as far as the recording, it will be posted on our EMR-embedded website, which we have the link in the chat, and we can repost that for you. And it takes us about 4 weeks to get that posted. So there's some prior webinars listed there that you could listen to those recordings, but that will be coming in the near future.
Jennifer, can I add something as far as our IT analysts?
Absolutely.
Okay. I have to say I've been doing this job for 8 years. When I first started this job, I felt like there's a very big disconnect between the navigators and the IT analysts, and it was very frustrating for me. But as I continue to reach out to IT analysts, put in our tickets for what we needed for heart failure, I found that a group of analysts came together, and that they had a lot of the abilities and a lot of the knowledge that we needed. I think there's a big disconnect between what navigators want and what IT analysts know. And if you can get together with your analyst team, you will be really surprised that they have what you need. They just don't know what you need. And so, just reaching out and getting the right group of people involved made a huge difference for me.
Yeah, that's wonderful insight. Thank you for sharing that, Geri. Another question for the EF, where is it being pulled from? Provider notes or an echo report?
From the echo report. So it's a discrete EF from the echo report, and it pulls back from the last 12 months.
Thank you. So many wonderful questions. There was one about rounding. Someone said, I wish I had Epic. Let's go back to a question regarding the sticky note. How do you share your heart failure list, and does that include your sticky note information?
Yes, so my heart failure list can be edited, and I can really share it with any provider or staff member. It's completely customizable on my end. So I just go into properties and I just add the person's name. So if I have an extra nurse navigator, outpatient nurse navigator, for instance, that just started, I can put them in there and it will show up on their patient list automatically. If I have somebody I'm not sharing with anymore, I can edit it and take them off. And the second part was, my sticky note. So my sticky note is my sticky note. I just keep track of it. I remind myself about the patient. There is a way within Epic to share your sticky note with a group. I haven't needed to do that. But I know that the pharmacists all have their own sticky notes and they share it amongst the pharmacy staff. So I know there's a way to do it. I haven't had to do it.
Thank you. We will round it off with one additional question that I think each of you could probably comment on. Are the multidisciplinary rounds every day and what time?
Yeah, so our rounds are Monday through Friday. They're at 1:30. They previously were kind of mid-morning at 11 a.m. and it just got to be challenging as a lot of teams hadn't completed their morning rounds yet. So they meet in the same conference room outside of our CICU. And it really is, it's 30 minutes covering actually 6 different cardiology teams. So our 4 cardiology services, our advanced heart failure team, and then our consults post-procedure team. So it's really kind of, like I said, rapid fire, 30 minutes total to cover all of those patients. And it's really kind of just trying to address like what's holding the patient up for discharge. Some patients may not even be close to discharge, so they can kind of just move on to the next patient on the list. But it's got very well attendance. Our case managers do a good job of making sure that our providers are there and are timely. So it's been very productive and a great way to get the team all together for 30 minutes each day.
I used to do heart failure rounds, and it was probably an hour, hour and a half to go through the entire Memorial Hospital North. But I just ran out of time trying to look for these patients, identification, put all the education on. I find that it's easier for me when I identify a heart failure patient to send a chat message through Epic to my case manager or my nurse that's taking care of the patient and communicate with them that way.
I love that, 2 different perspectives. You know, there's different ways to do things. There isn't like a one silver bullet for everything. So I appreciate that. Well, this concludes Implement EF's Advancing HFpEF, HFmrEF Identification webinar. We want to thank you very much for attending today's webinar. You will receive a post-event survey with some questions to help us as we continue to develop future educational opportunities, and would greatly appreciate it if you took the time to complete it. This event was presented as part of our Implement EF initiative supported by Bayer. Thank you for attending today's webinar. Should you have any questions or feedback, please feel free to email us at implement.ef@heart.org or visit our initiative website. This concludes today's webinar.